Hello from Trinidad and Tobago and the Caribbean Venous and Lymphatic Society. This is a similar presentation that was done for Veith 2024 on venous thermography and its clinical use. We have no disclosures. Duplex ultrasonography is well established as the gold standard investigation for venous disease. So why look elsewhere? DUS has several limitations, including the need for expensive equipment, specialized training to perform. It is operator dependent and can be long, tedious, and potentially painful, leading to missed pathology. So, what's the answer? Maybe a preceding screening test that is quick, sensitive, and specific, non contact with no patient discomfort, involving the use of inexpensive equipment with little need for highly trained technicians. So, is there a screening tool that can be used to obviate these issues and be used as an adjunct to DUS? Thermography may hold the answer. Thermography is a non-invasive technique using thermal radiation to measure and record temperature patterns and distribution in the body. The skin's surface temperature correlates with underlying tissue heat, in this case, venous blood flow. Core temperature is about 2 degrees higher than peripheral skin temperature. Refluxing blood from the deep system into the superficial system heats the overlying skin. This thermal energy or radiation that is generated lies within the infrared electromagnetic spectrum. A specialized camera detects the thermal radiation pattern within the infrared range. It was thought that the increase in heat generated in the incompetent veins was due to perivenous inflammation. But look what happens when the patient adopts a supine position. The thermogram looks normal. I'll explain this in a bit. Thermal imaging has been around since the 60s. Infrared cameras have come a long way, with novel cameras being portable, more accurate, with cloud storage facilitating international research and even artificial intelligence interpretation. So let's look at some cases and data. Here is an obvious case of reflux involving a superficial tributary of the GSV and the respective thermogram, just to put things in perspective. Here is an incompetent vein over the Achilles tendon that may alter the medial and lateral zone of influence, which we have dubbed the Trinidad crossing vein. What happens when we are faced with patients with high BMIs? DUS can be tedious, and unusual patterns of superficial venous insufficiency can be easily missed, even in the most expert hands. Thermal imaging may have a role for follow-up treatment. This patient underwent laser ablation of an incompetent great saphenous vein, but had little improvement in lateral leg discomfort. This lateral perforator was missed on previous ultrasonography, but easily detected on thermal imaging. Subsequent sclerotherapy ablated his residual symptoms. How many of you are inundated with referrals for this condition? While perforator incompetence can be excluded clinically, thermal imaging will confirm no increased heat pattern associated with reflux. Let's look at some data. Sofa and colleagues demonstrated an almost 25% increase in the detection of all venous reflux segments when thermal imaging was used prior to DUS, compared to DUS alone, in two separate cohorts 2 years apart. There was an increase in the detection of anterior and posterior accessory great saphenous vein incompetence, but this was not statistically significant. But there was an increased pickup rate of short saphenous vein incompetence of 36%, and this was statistically significant. A retrospective study by the same authors comparing thermal imaging findings and the gold standard DUS demonstrated a sensitivity of 98%, a specificity of 100%, and an overall accuracy of 98.5%. They also highlighted that the thermal emissions detected are due to the core blood refluxing onto the surface. Let's look at thermal imaging and the key classification. Dalavos and colleagues demonstrated a significant thermal increase in skin temperature in C2 versus C4 patients of 1.8 and 3.6 degrees Celsius, respectively. Another study demonstrated a similar correlation but concluded that this was weak due to the small subject size. Patient education or lack thereof has shown to seriously affect patient compliance with frequent regimes, particularly compression therapy. Thermal images present a graphic, more lifelike picture of varicosities and can be easily explained by all levels of staff. We have found this in our clinic since its introduction in July 2024. Thermal imaging has a place in wound care centers, facilitating early diagnosis of chronic venous insufficiency and allowing for possible early targeted treatment, including compression, especially in regions where duplex imaging is not readily available. So, what are the limitations of thermography? Thermography may not detect deeper superficial venous insufficiency, especially the proximal GSV, which lies within its own fascial compartment. Thermal signatures of superficial venous incompetence may be obscured in certain anatomical areas, for example, the popliteal fossa, the anterior tibial border, and over hamstring tendons. Superficial venous insufficiency is also obscured by inflammatory conditions of the skin, even including acute tattoos. Thermography may not detect deep venous reflux and deep venous pathology. Thus far, there is no accepted procedural protocol, and most of our data is based on studies that are small and primarily retrospective. So, before I'm executed by our ultrasonographers, remember DUS still remains a gold standard investigation for venous insufficiency, but thermal imaging can be a useful precursor test, though a lot more work needs to be done. Thank you.